On behalf of the Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for attending our webinars. The audience has reached a huge number every week, and lectures have been excellent. Today, our topic is selection of patients for DBS, and we have neurologists and neurosurgeons to discuss this topic. Dr. Paulo will present the speakers and the panelists. So go on.
Welcome to everyone. I would like to thank all for being here today. Today's topic is patient selection and eligibility for DBS and Parkinson's disease. In Parkinson's disease, patient selection for surgery should be performed by a specialist in movement disorder with experience and clinical and surgical treatment. The DBS application is generally established according to the proposed inclusion and exclusion criteria after a thorough and a specific assessment for surgical, interventional therapies, and PD. Today, we have a very important group of panelists. Professor Clécio Godeiro is a professor of Federal University of Rio Grande do Norte, Brazil. Professor Gilberto Fonseca is a neurosurgeon, Hospital Madre Teresa, Belo Horizonte, Minas Gerais, Brazil. Professor Gabriela Gilardi is a neurologist, Hospital do Coração de São Paulo, Brazil. Professor Rômulo Marques is a neurosurgeon, Hospital Araújo Jorge and Instituto do Neurologia, Goiás, Brazil. Many thanks to everyone for accepting the invitation from Brazilian Society of Functional Neurosurgery. Our speaker couldn't be better. Our friend, Professor Renato Munhoz. Professor Renato has a graduation medical residence and obtained his master and PhD master at the Federal University of Paraná, Brazil. He was research and then clinical fellow in movement disorders of University of Toronto. And actually, Professor Munhoz is a professor of neurology at University of Toronto, Movement Disorders Unit, Toronto Western Hospital, Canada. Professor Munhoz, the stage is yours.
Well, thank you all for the invitation. I'm really proud and happy to be here today. I know that this series of talks is really done by very renowned people in the world, and I'm really proud and happy to be among them. So first of all, I'd like to thank the organizing committee for inviting me, Professors Antonio and Paulo, my friends, and all the audience that reserved their valuable time to be here today after I'm pretty sure a very busy week and a very busy day. So I'll try to stick to, so Dr. Paulo Brenner gave me 30 minutes to go over this topic. I think it's enough to cover most of the basic aspects, and I'll try to stay, up to the time that he reserved for me. So every time someone asks me to talk about DBS in general, I asked back, what's your that I can help? The main topic that the people ask me is this. So how do you do patient selection? How do you determine eligibility for DBS in Parkinson's disease, in motor movement disorders? The second most important, more common topic people ask me about is how to do programming, and also how to manage pitfalls in programming. From my point of view, there are three main topics to have a successful outcome after deep brain stimulation surgery, and select the right patients is one of the cornerstones of this process, right? Of course, the technical skills of the surgeon is essential in this point, because placing the electrode in the right spot, performing the surgery with no complications And also the third most important aspect would be programming. Programming is key. Programming should be well done, and I'm pretty sure you have that topic covered by someone else here. So what I'll try to cover today is basically the indications for DBS in Parkinson's disease mainly, right? How I do the selection process, and how do I select the right patients for this procedure, right? So first of all, I would like to make clear that the targets that I'm going to talk about are or let's say the orthodox targets that we use for deep brain stimulation. That includes, in some cases, the VIM, right? In patients with tremor-dominant Parkinson's disease, occasionally, the GPI, and the subthalamic nucleus. I won't go over the more unorthodox or the experimental targets that we use for these procedures, right? So this, as I mentioned earlier, this is one of the talks that I give more often in this field. And actually, I was every time I'm preparing or reorganizing my talk, I go over all the slides and all the details. And most of all, I try to keep up with the literature and with in my own experience, basically, right? And I have to be honest with you, this is a moving target. This is a dynamic topic that changes every time. Right? Every time I need to review my slides and review the topics I'm going to cover, things change, right? And that reflects the fact that we learn with experience, right? And several of the aspects of what we do here are very subjective. It may be a topic for heated debate. For instance, how do I select patients in terms of age, in terms of cognitive status, and these things. So this is a moving target, as I said. So things may change. You may have different opinions. I'll be happy to discuss why I do things the way I do. And this is basically just a framework. It's not a definitive. In my word on this is something that definitely that's worth to be debated and discussed and changed, if there's a good reason to do so. Right. So starting with how to select patients. First of all, we need to figure out and establish very clearly what to expect from this procedure, right? So the first thing you can promise patients, or you can give patients a good promise with a good chance of achieving it, is to improvement of the motor signs of Parkinson's disease, in particular the non-axial or the appendicular signs of Parkinson's disease. And here we're talking about rigidity, we're talking about rest tremor or postural tremor even, and we're talking about bradykinesia, right? So when patients ask me what are the motor problems that can be resolved, those are the ones that I can for sure advice, right? So these are the ones that are very likely to improve, right? Also, you can get a very good improvement in motor fluctuations. And actually, motor fluctuations is one of those indications that, one of those complications of long-term treatment and disease progression that can be very well addressed by DBS. So the way I describe this to patients, to give them a realistic view of what to expect in terms of improvement in motor fluctuations and mobility, is to remind them how they fluctuate throughout the day, right? So they start the day being off, being with very bad mobility in general because they're off medication. They take the first dose, they improve, then the medication wears off, they take another dose. So they go up and down, peaks and valleys throughout the day, right? So, and this is something they experience, they know, they experience this kind of fluctuation throughout the day in their daily lives, and that's their life from at that moment, right? So what surgery will do for them, so sorry, before moving to the effect of surgery, in addition to the fluctuation, you have a certain threshold in the levodopa level in which patients experience dyskinesia. These are the most typical peak dose dyskinesias, right, we're talking about. So when patients, so they improve their mobility, when they reach a certain level of serum concentration of dopamine or levodopa, they have peaked out dyskinesias, right? So, so they experience dyskinesias, they experience motor fluctuations, and what surgery can do for them is that after, once they have an optimal setting programmed in their deep brain stimulation device, they will never be as off as they were before surgery, right? So there will always be an effect of stimulation that is much higher than the off period that they used to experience before surgery. And then what we see after surgery is that the fluctuations that they will experience with medication is something much more subtle, right? They will not fluctuate as much. Some patients, they continue to fluctuate, but they don't even notice that they're fluctuating anymore. So they have this sensation, they are continuously on for most of the time. And the moments that they cross the line of the threshold for dyskinesia, that cross the amount of time that they remain above that threshold can be diminished by reducing the amount of medication, right? So they fluctuate, but the fluctuation is much more subtle, and their dyskinesia is also much more subtle, much more discrete than before surgery. So what else can we expect? So we can expect a potential reduction in the levodopa-induced dyskinesia, right? So that can be achieved in two ways, right? If we are indicating GPI stimulation, so GPI has a direct effect on blocking dyskinesias, right? As we all know. STN, on the other hand, it mainly makes the whole basal ganglia circuitry more sensitive to levodopa. So in other words, they will have, if they remain on the same dose of levodopa, they will have more dyskinesia, right? So basically their circuit will be more oiled, well oiled in terms of when levodopa or dopamine is added to the equation here, right? So the effect of ST and DBS in reducing dyskinesia is indirect and mainly related to the amount of levodopa that we need to reduce after surgery, right? So it is very important to keep in mind that after ST and DBS in particular, you not only can reduce the amount of levodopa, but you need to reduce the amount of levodopa, right? Some patients cannot tolerate their previous doses of levodopa anymore, right? We can also expect that we will change the medication regimen. So for STN, I just mentioned why, right? We need to, reducing the amount of medication is not a luxury. It is something we need to do, right? You need to do that. And for GPI, the effect is that it allows you to have more flexibility in your medication regimen. It's not that you can cut down doses of levodopa, for instance. It may be actually the opposite. In patients with overt dyskinesia that you cannot give more levodopa, after GPI DBS, you may gain that opportunity to offer more levodopa because the patient does not suffer from the dyskinesias as much as before surgery. So what is the effect on the axial signs of Parkinson's disease, right? So this is a key feature, a key problem here. It's something that needs to be very well addressed before surgery. The effect on gait and balance is quite variable. It goes all over the place. Some patients improve, some patients don't change, some patients can get worse after surgery, right? Especially if they need levodopa, for instance, to keep balance, and you need to reduce levodopa after ST and DBS, right? So when you talk about gait and balance with patients, you need to make clear that that's not their main problem, right? If that's not their main problem, even with the most successful surgery, you may still be fighting with the same problem after, and patient may be disappointed because he may be expecting improvement in that feature. What's the effect on speech? So speech can get worse. This is something we need to tell patients, right? Especially after STN, especially after bilateral STN, right? There is even early this week we had I know most of you might have followed the MDS Congress in the Movement Disorder Society Congress, and there was a specific talk on speech after DBS in general, and they showed very good data outlining something that we know in practice, the fact that STN is much worse than GPI when you're talking about speech. But despite that, GPI can also make speech worse, right? So you need to tell patients that STN surgery can worsen their speech, and this is quite consistent, quite common, right? So if the speech is good to begin with, it can get worse, not too much worse, but it can get worse. If the speech is bad to begin with, that's a main problem. Then think twice about surgery. For instance, I have patients who come to me who are preachers, for instance, who are lawyers, who work in a position where they need to talk to work, right? That's an inherent part of their job. And if we are to indicate patients for surgery in their circumstance, again, think twice, or think about GPI DBS, or if you need to go for STN, think about directional lead. There are variables that we need to include in this equation if your speech is important here. Cognition is may not be affected if it is good to begin with, right? But it can be very, the effect can be negative if the patients are in the verge for or dementia, or if they have an overall not good cognition, right? So that's why you need to have a very thorough, very detailed cognitive assessment before surgery to determine patient's eligibility. We'll go over that in detail a little more. Sleep, interestingly, can be improved by surgery. I don't think in particular that that's a physiological effect. I think that's an effect of having better mobility throughout the night, right? So patients can move better. They can find a more comfortable position to rest and to sleep, right? And can adjust their blankets or adjust their pillows and sleep more comfortably. That's why they sleep better, right? That's my interpretation of this. And this is very consistent. Patients report improvement in sleep. Also, we can have a very good effect on side effects that are related to medication, right? Sometimes patients take those medications forever and they don't even recognize anymore that they have a side effect. For instance, nausea, some cognitive slowing, some, it goes all over the place again. So it can have many features that patients only recognize once they reduce or stop certain medications. So they will tell you, well, I'm much sharper in my cognition after I stop taking, for instance, amantadine, or after I stop taking the Artane, the trioxyphenidyl, bipyridine, whatever. So when they stop certain medications that they used to take and they don't even notice a side effect, they look back and say, yeah, that was messing my mind or something like that. So this is an example of a good response to DBS, right? This is a patient that was followed longitudinally, initially by Dr. Elena Morrow. Now she's followed by me. So this is a patient, you see very bad postural instability, small steps. The patient is in the off condition prior to surgery. And you see how stiff she is, how short their steps are. And you see this patient after 5 and 10 years, right? You see better mobility in general. You see the pull test improved. You see even the steps are better, larger, better amplitude of steps. That's consistent over 5 and 10 years. And you see, if you can remember the beginning of the video of this particular 2 videos, you said that the face didn't change, right? So that's one of the axial motor features that we don't see improvement, right? Facial expression. A similar situation for this other patient. Look at their face, look at the overall mobility. This is prior to surgery again. Very short steps. Patient stiff as a board in the off condition. bad posture and stability. The pull test, unfortunately, was not properly done, but you see the patient would fall if the patient was given a proper pull test. You see the patient in the off, again, off medication, on stimulation after 5 and 10 years. Same nurse again. You see the steps, good posture in general, right? This is a successful outcome of DBS surgery, right? In this case, the exception of the general rule is the improvement in gait and walking, right? So this may be like a, one of those poster cases to be presented. So what's next in terms of a good selection of patients? So patients need to have a good response to levodopa. This is essential. There are many reasons why this is important. First of all, only patients with pure Parkinson's disease respond well to levodopa, right? So by doing this and finding a good response to levodopa, we are making sure that this patient has PD, not something else that is mimicking Parkinson's disease, right? Second of all, we know that the dimension and the type of response that we see after a good levodopa challenge reflects what we expect to see from surgery, right? So the best response comes from the patients with the best response to levodopa, right? So this is very important. The next slides, I'll talk a little bit more about how we do the levodopa challenge. So you need patients also who have a longer than 4 years since disease onset. That's very important to make sure, again, that the patient has really Parkinson's disease and not something that is just quietly behaving like Parkinson's disease in the beginning. It may be manifesting later as PSP or something else, right? So this is important to keep in mind. Sometimes patients have a relatively benign first years into the disease, and then they develop a more dramatic and refractory clinical presentation after a few years, right? Age is a very controversial topic. There are a few articles published recently that try to change our minds in terms of this cutoff to indicate surgery, but still the 7 years old threshold is something that we take it as a rule of thumb, let's say, right? This is something that the surgeons in my center here take it very seriously. Especially the head neurosurgeon here, Dr. Lozano, he's very strict in his indications in terms of age. Some others are a little more flexible. And to be honest with you, we see patients that are like the good 72, 73, and we see bad 67, 65s, right? So we need to be slightly flexible in this, in using this, to use this cutoff, right? Because this is something that changes and is quite variable from patient to patient. But to be honest with you, what I'm seeing more recently in my experience, especially over the past 5 years, I've been noticing that even the good 73s, they don't have a response of the ones that are younger than 70. I think the 70 years old cutoff is something to keep in mind. It's something valuable, I think, still. This is just to show that this is really indeed true and that we should try to indicate patients as soon as they reach a certain level of disability and have the right indications, regardless of age, or a young age, I mean, right? So this is a study that tried to look at what's the quality of life of patients after a successful treatment with ST and DBS. And you see that, and they stratified this group of patients by their age, and you see that those are younger than 59 or than 60, sorry, are the ones who have by far the best improvement in quality of life, followed then by those that are between 60 and 70, and the worst are the ones that are 70. Of course, there's a bias here, right? So patients who are younger than 60, they perform many other activities, especially professional activities in sports and in social activities that are natural to people in general that are younger than 60, right? So they have more items, a better score to keep, right, than the ones that are older. So the other aspect in terms of indications is that these patients, we need to have motor fluctuations in dyskinesias, right? This is basic, right? These are the complications that we want to improve with the surgery. These are the main complications, right? And this is something that can be quite dramatically improved by surgery, despite doing all the all the maneuvers and all the using all our knowledge and flexibility in trying to change patients' therapy. Patients still remain disabled, so we need to select this type of patient. These are the patients that will have the best, will gain more with surgery. So, and additionally, now comes the issue of the levodopa challenge, right? So we need to have an improvement of 30 to 40% in the levodopa challenge, right? Different centers use different cutoffs. We use here 35 to 40, right? I know that in Germany, they use 50 to select patients. In other centers, they use 30, right? There are many exceptions. One of the main exceptions, I think the one exceptions that I accept to that is patients who have a suboptimal improvement, but their scores, both in the off and the on condition, are driven by tremor, right? Tremor may not respond to levodopa, but it can respond quite well to DBS, any target, right? So the ideal candidate is someone who is severely disabled when the patient is in the off condition and is independent in the on condition, right? This is the good patient, right? Basically someone who fluctuates from being one person to another person, if you look at the way they function throughout the day, depending on the effect of levodopa. The way we do the levodopa challenge, right? This article that I'm advertising here in this slide is one article that has covers many aspects of DBS. One of them I gave my tips on how to do the levodopa challenge using basically the method that we do here at the Toronto Western Hospital, and that includes scoring the patient in the off condition. So the patient comes to the hospital in the off condition early in the morning, right? Sometimes that's difficult, but that's necessary. That's something we need to tell patients. So they will be very symptomatic. They will have difficulty coming to the hospital. And then you score the patient with the UPDRS part 3, which is the motor part. And then you give the patient a good dose of levodopa. That dose is usually in the range of 1.25 to 1.5, or the usual levodopa equivalent. So there is a table that we use to define that levodopa equivalent. If you want, in this article, you have that article, the reference to that article, and you calculate the levodopa equivalent, multiply by 0.5 or 0.25, and then you give the dose to the patient, wait for the medication to be fully kicked in, to be fully on, and then you re-score the patient. After you re-score the patient, you do the math, right? The math basically involves you subtract your off score, which is higher, right, obviously, from the on score, which is lower, and divide by the on score, right? So with that, you obviously will have a score that is lower than 1, right? Is between 1 and 0. You multiply that by 100, and you have a percentage, right? So that percentage is the one that we use to calculate this response, right? Again, the better the response, the best results. Other supportive criteria include young age, severe tremor, right? Severe tremor is not responsive to levodopa many times. Need to simplify medication regimens. They are very complex. Need to avoid side effects, certain side effects. Sleep, maybe, you know, one of those ancillary, one of those minor criteria to indicate surgery, but still it is a criterion. Mood must be stable, right? It's very unusual to find a patient with, let's say, a pristine mood in Parkinson's disease. You often have some traces of anxiety, depression, some mild psychosis because of medication, these kind of things. So the patient needs to be stable at least, right? It doesn't mean that if the patient are depressed or they have had depression, they are unfit for surgery. They may still be fit for surgery if that problem has been solved. That would be a reason to postpone surgery, but not to contraindicate surgery. ICD, so impulse control disorder, and dopamine dysregulation syndrome are not, from our view, in our view here, and this is a consensus we have with the surgeons, with ourselves, with our psychiatrists, ICDs and the dopamine dysregulation syndrome are red or yellow flags, depending on how you see it, for surgery, not a green flag. Some people, so when you see this, you have the impulse to say, well, I'll get rid of medication and get rid of this problem. That's not something that happens consistently, right? Actually, ICDs and DDS may be the tip of the iceberg of another more severe problem that is just hiding below the surface, right? So, and after surgery, if you need to reduce medication, you may be in trouble, right? Because you may be needing to reduce medication because of motor issues, but in fact, because of non-motor issues, because of psychiatric problems, because of mood problems, the patient will still need these medications, right? So ICDs, DDS, not a good idea. Refractory psychosis is, again, not a good idea. Again, this may be the tip of the iceberg of a progressive or the beginning of a steady decline in cognition, right? And again, cognition is a whole different teaching session on DBS, because there are many nuances, many subtle differences, and many variables to be considered, right? Patients with dementia, no surgery. Nobody questions that. MCI is another story, right? We don't have very clear, very absolute evidence, but we have good evidence that STN is more harmful in terms of surgical outcomes, cognitive outcomes of surgery, and STN should be avoided in patients with MCI, right? Should be avoided. GPI is a safer target. We have good experience in showing that. We don't have clear-cut scientific data showing that, so clear-cut evidence, but we have good clinical experience with that. In terms of other issues, so patients will be physically fit to take the surgery, right? So we're talking about here clinical comorbidities, heart diseases, infections, malignancy, any disease you can think about is a long list. Patients should be stable, and patients we should envision patients who will be able to experience and be benefited by the good effect of this surgery for a long time, right? This is a procedure that we need to be cost effective. Patients need to live long enough to experience good benefit. Imaging is something that is more, I think, in the hands of the surgeon to judge, right? Yeah, if there are distortions in the anatomy that can be addressed by stereotactic technique, good. But otherwise, we should definitely question the indication for surgery if there is a gross abnormality in brain anatomy, structural pathology I'm talking about. Also important, patients, very important to consider this. Disability must be related to levodopa responsive features, not to levodopa unresponsive features, right? Again, for the same reason that I mentioned earlier, I'm now reinforcing this aspect. Disability I'm not saying that patients should only have features that are levodopa responsive, but their main disabilities should be related to this kinds of problems, right? Psychosocial factors. So I'll go over some of this in one of the next slides. I'm almost done here. So employability, interpersonal relationships, support, family support in particular, very important. So keep in mind, this is a table that I did published a few years ago, and this shows a literature review of how much improvement you can get with each of these techniques. So you see that comparing even the contralateral improvement that you see in a unilateral polydotomy, that's in keeping with the improvement you see after DBS with GPI or STN as targets, right? So it's quite similar, right? The improvement in dyskinesia, if you look at the maximal improvement, is similar between all these techniques, right? STN, the margin is a lot broader for STN, and this is again relies on the fact that if you're not able to reduce the amount of medication after STN DBS, you may be stuck with patient with dyskinesia still, right? So that may not change as much as you wish. But on the other hand, if you need to reduce medication, STN is the best option, right? Yeah, because you don't get a meaningful improvement in the amount of dyskinesia of levodopa or levodopa equivalent medication after GPI as a target. So the good patient to be selected for GPI are those patients who are on low dose of levodopa, and despite taking low dose, they have prominent or brittle dyskinesias, right? So if these patients have low threshold and overt dyskinesia, GPI may be the best option. The patient with, this is a very, let's say, broad statement I'm making here, because it can be debated very easily. I'm not saying that this is a rule of thumb, but I'm just saying that this is something to keep in mind. For STN-DBS, if patients are on high doses of levodopa, and they should, the STN would be a better target, right? Another important thing to keep in mind is if those patients who need levodopa to treat their non-motor problems, right? Patients who need levodopa to treat their non-motor problems, for instance, anxiety, for instance, cognition, some patients improve with levodopa, right? We see that. And so these patients need to take, to be on GPI, because you still continue to have a good dose, and even will allow you to use a better dose of levodopa sometimes. So this is a graph, I'm almost done in my presentation. I just want to finish with this. So this is a graph that shows how early you can, how important it is to find the right timing for surgery. So this is a graph that shows how the motor function changes over time. So in the beginning of the disease, this is time in the disease, right? So we see in the beginning of the disease, there is a rapid decline after a certain point. Then there is a relative plateau and the progression of motor severity, and then the axial symptoms of motor action symptoms start to be noticed, right? There is also some kind of adaptation that we see in these patients, right? During the initial phase to middle phases of the disease, there is a certain room for adaptation, right? But after a certain point in the disease, the symptoms are so widespread and severe that there's no way to rescue anymore, right? In terms of psychosocial changes in patient's life, right? Traditionally, surgery was indicated at this point. At this point, what we could get is a good improvement in mobility. So the motor scores will improve. But on the other hand, those problems that are non-motor, social, family issues, employability, and this kind of thing, despite the improvement in mobility, you don't get that kind of improvement in psychosocial life, right? So you're stuck with a patient that has good mobility, but cannot fully appreciate those benefits. The idea is not to indicate the surgery much earlier than that. If you indicate surgery before a certain cutoff in which there is still time for adaptation, there is still time for the patient to regain certain aspects of psychosocial life, that's the right moment, right? That's the right moment to indicate surgery. Not too early, not too late, particularly emphasis on the late part of this, right? And this is something that was very elegantly showed in this trial. So the neuro is called early STEM trial, was published several years ago. And basically what they did is to select a patient who were younger than 60, who had good postural instability, you see by the Honeyard score, so no postural instability, and had a disease of higher, more or equal to 4 years old, 4 years of disease duration. They need to have a 50% improvement in levodopa challenge and still had the fluctuations or dyskinesias as indications for surgery. And what this study showed was that patients so they compared in this study best medical therapy and stimulation in the early phases, right? And what they showed in terms of functionality, in terms of improvement in mobility, and improvement in quality of life. So these are in the bottom, you see here the scores of quality of life, the domains of quality of life. And you see that there was a disproportional and very significant improvement for the patients who had this early surgery, right? So this is something that reinforces the need to indicate surgery at this point, right? So I will stop at this point, I would like to again thank you for inviting me. I'll be happy to discuss everything that I mentioned that you don't agree or that you don't understand clearly. I'll be happy to discuss those topics with you. Thank you very much.
Okay, Professor Munhoz, we have had an excellent lecture, objective, provocative. Congratulations, Professor. Now I would like to invite our moderators for comments and questions. First of all, Professor Clécio. Professor Clécio.
Hello, thank you, Paulo, for this invitation. Thank you, Antonio. I'd like just to give a historical background. Paulo was the responsible to present me to Professor Moro and gave me the opportunity to learn a lot about DBS in Grenoble during 2 years. And thank you, Paulo. I'll never forget that. And thank you, Renato. It was a very comprehensive presentation, very provocative. And I saw in Q&A one question about the levodopa challenge. But I'd like to start with one comment about the levodopa challenge. During the MDS Congress, there was a debate about if is it still necessary to have a levodopa challenge, especially if the team that's going to perform the surgery is the team that follows the patient during years. And you have comment during your presentation that if you know that during the off period, the patient is severely disabled, and during the on condition, the patient is independent, maybe that's a clue that the patient responds to levodopa. And there was different opinions. For example, Michael Kuhn believes that maybe we could avoid the levodopa challenge, especially in conditions that the patient doesn't tolerate the test. And Gunther Dunschel thinks that the surgery is just one shot, is that one opportunity in life and must be perfect. As you comment, for example, Lozano that wants the perfect patient for surgery. And I'd like to have your comments about this subject. Is it still room for levodopa challenge? Is it still necessary, or we can use our clinical observation, the follow-up the patient to have this decision?
Yeah, that's a very, very good point. And from my answer would be absolutely necessary. I don't see a room to, I don't see nowadays room to avoid it, a room to avoid it before we have another marker, right? If we could find another marker for successful surgery, we could avoid it. I absolutely think this is essential for surgery. I think the impression of, the subjective impression of improvement can be, decisive sometimes, and divisive. I mean, and I definitely think that is necessary. This is something that it's not only necessary to to measure objectively the response to levodopa. I think the Germanic view of Dr. Deutschel is to have to have this the Cartesian decision about surgery, and I think this is very valuable. And not only that, I think that for instance, my boss here, my mentor here in Toronto, Dr. Tony Lang, he once questioned me and my colleague, Dr. Fasano, what's the usefulness of doing the post-op capsid? So the post-op levodopa challenges, which is a little more complex, right? And in that, because when I do a levodopa, a post-op capsid, it is one of the most incredible learning experiences you can have for fellows, for us, and for the patient, right? And you need a parameter to compare, basically, right? So after surgery, so those who are not familiar, the post-op capsid involves seeing the patient off medication, off stimulation, on medication only, on stimulation only, and with both on. And then you do all this math that I mentioned before, right? And you have the percentage of improvement that is driven by medication alone, surgery alone, and a combination of both, right? And this is an incredible learning experience. This is an incredible learning experience for the patient. So the patient can be reassured at that point, that the surgery was valuable, right? We can reassure ourselves that we are doing something valuable. And we can compare with how the patient was before surgery. And it is very amazing to see that sometimes after 20 years of disease, you do a post-op capsid, and you see the same amount of improvement with, for instance, with levodopa after 20 years. The same percentage or a similar, I'm talking about obviously not the same, but similar, right? And again, I think this is a very important piece in the decision-making in surgery. I wouldn't, for me, the only exception, as you mentioned, and as Michael Ocon mentioned in that talk, and I've had this situation half dozen times in my professional life, patients who cannot tolerate levodopa, then it's another story. Then you can maybe skip it, rely on your judgment that this patient really has PD, and move on.
Perfect. I totally agree with you with your point of view, but I think sometimes it's difficult to have a good levodopa challenge, especially for those patients that do not tolerate levodopa. In France, we used, for example, pre-medication for nausea, vomiting. Sometimes it was not possible. We had apomorphine. I don't know if in Toronto you use that. But in Brazil, for example, we don't have that, and the only option maybe it's levodopa or some oral agonist, dopaminergic agonist. I'm not if the other panelists have different point of views, but I totally agree with you. Thank you very much.
We don't do the apomorphine challenge. We have apomorphine just recently introduced here, but we don't use it. We don't do it as for that purpose. And again, we do like domperidone before. For patients who are sensitive to higher doses, we do the same thing. Yeah.
Great. Now I would like to call Professor Gilberto Fonseca.
Okay, thank you. I would like at first to congratulate Professor Renato Munhoz for the brilliant class on the best choice of DBS candidates. I want to say that here in Belo Horizonte, we have some experience and we have opportunity to work with multidisciplinary team, neurologists, neurosurgeon, neuropsychologists, physiotherapists, speech therapists, and that's play a very good thing. I think it makes a lot of difference. In the beginning, I did the procedures without this team, and I can say for sure that the results are much better after that. And I want to thank Dr. Raquel Branch that make for us this team working. And I want to know, because here we do perform almost every case STN. What do you think about the target in your team? You do more STN or more GPI or both? Or, well, I want to know it.
So thank you for your question. So first of all, you might know that you have a brilliant neurologist that we trained here that is in Belo Horizonte, Ricardo Maciel. I think he's at the Federal University of Minas Gerais with Dr. Francisco Cardoso.
Yes.
So he trained here. He's a brilliant neurologist, well-trained in many aspects. Before us, he was well-trained by Dr. Cardoso in São Paulo as well. He's a brilliant. So you have very good options in terms of programming. So again, now moving to your question. So here we do both targets, right? There are nuances in the indication for each of them, right? And there used to be, at least in the past, groups that were radically in favor of STN, radically in favor of GPI, using different ways to justify this selection. But I'm pretty sure that nowadays most centers are open to both targets, right? Our preference is for STN. I think that's it is still the most preferred target worldwide. I think there, with a few exceptions, right? Mainly because the effect is more dramatic. You know, we often see patients who have those beautiful, very good results. The patients who walk on the streets, they live their lives after surgery. I mean, without no one noticing that they have PD, right? With no exception, you may have your own cases, but with no exceptions, those are STN patients, right? I think that cosmetically, STN is the one that gives the patient the look of a normal patient. STN DBS, right? GPI, it has a good result. It has their own indications. It has their own contraindications. But, you know, those are patients that they don't have the same amount of result. They have good results very often and very commonly. But, you know, those patients that have these spectacular results are, from my experience, are STN patients. And the reasons to choose one target or the other, again, is a very long debate we can have, but mainly are patients who, you know, there are parameters that we use in terms of cognition, in terms of the response of non-motor signs, in terms of how much medication they take, how much dyskinesia they have, and so on.
Okay, thank you, Professor Renato. Very, very nice lecture.
Great, great. Now I would like to invite Professor Gabriela Gilardi. Professor Gabriela.
Hello, I'd like to congratulate you. And nice to meet you. Finally, I heard so much about you from a lot of people. I'd like to say a little bit about the level top challenge test that Clécio told. I think for us that are neurologists, it's an incredible tool to learn movement disorders. You can learn so much doing that and learn about your patient, because sometimes we follow the patient for a long time, and when you perform a test, you notice, he gets that side effect, it's different. So I agree with you that it's really important. And what I noticed is that you just don't have to give a super high dose of levodopa to see the effect. Sometimes when you give a lot of levodopa, they get into some high. I don't know if you have noticed that. And it's not what we want with the DBS. And but my question for you is about the axial symptoms and DBS. How do you deal with that when you are with a patient in front of you and that he wants to perform surgery, especially for balance? That, in my point of view, is the axial symptom that we can have more negative effect with the DBS.
Yeah, so thank you for your question, Gabriela. So with regards to, so I share your impression that as clinicians, doing a levodopa challenge is a beautiful thing, right? It's something that you can see, you can learn a lot. Our trainees learn a lot, and by seeing that, and the patient learns a lot. So again, I'm moving to the question of how would you manage the axial symptoms, right? So it depends on which axial symptoms. There is good evidence that low frequencies. You mean after surgery, right?
And before, when the patient
okay.
already has some axial symptoms, how do you explain it after manage?
There is a difficult topic, a difficult clinical situation.
Mm-hmm.
So you know, the medications that may be of use in a patient with axial symptoms, especially balance and postural problems, are so the ones that are, you know, levodopa, right, can have an effect, and then there are those that may work for some patients, may not work for most of them, and that includes amantadine, for instance, right? So there is good, so amantadine is classically now used to treat dyskinesias, but some patients may gain some improvement in their axial symptoms, especially balance and posture with amantadine. There is a very good article from the late 2000s that showed that amantadine after DBS, after STN DBS, has a very good effect. There is also some evidence, weak evidence of a good effect of methylphenidate, right? Mm-hmm. So methylphenidate, in my view at least, is that methylphenidate can improve dual tasking, or maybe, or actually may avoid dual tasking, right? You make patients more focused on what they're doing, in this situation, more focused on walking, right? So because the problem in PD is that they are not, patients are not, when they focus on something else while they're walking, for instance, when they think of something else, when they talk when they are walking, they lose balance because they're not focusing anymore on walking, right? So methylphenidate can have a good effect on focusing more on the motor activity, right? There is some evidence of, there's that article from, one or two articles with anticholinesterase agents, donepezil, I think, on reduction number of falls, right? Those are the things. So after surgery is another story, right? After surgery, there are a few different techniques of stimulation that can improve. For instance, we can try low frequency stimulation. In the case of STN, you can try ventral stimulation, especially if you use a longer electrode or the 2387 electrode for Medtronic. You can insert the tip of the first electrode, the ventral electrode, in the substantia nigra. That's something that surgeons often do. So stimulation of the substantia nigra may have an effect. You can use high frequency, for instance, to treat freezing of gait. Some patients improve, a minority of patients, but they improve sometimes. So that's a whole different topic, I think. right?
But what about the expectation of the patient with the surgery for the actual symptom?
Yeah, so then you
How
have
do
to
you manage that?
you have to keep patients keep their expectations low in regard to actual symptoms. If they can take the surgery just regardless of keeping their expectations low, good. If not, they should be very well aware of these limitations. They should know that. So there's a question from my friend Alexandre Francisco. Brilliant question, actually.
Renato,
If I answer it?
Professor Munhoz, please. It's the question from audience. We keep to the end, please.
Okay.
I would like to invite our moderator, Professor Romulo Marques. Thank you, Professor Marques.
Thank you very much. First, I would like to congratulate you for the beautiful and didactic lesson, and I would like to thank Paulo and Antonio for inviting me for doing this. So, if you have a patient with a massive tremor and dyskinesia, and you have to choose a target, you choose one, or maybe you can use like both, like two in multi-targeting. And if you do it, you would choose one for ablative way, and or like tremor and dyskinesia. Mostly my boss used to choose zona incerta as a targeting for that, and have a very good result. Maybe he could say afterwards. But if you have like speech problem and gait disturbance, would you choose like you put STN with a low frequency and maybe additional lesion in VIN for a better result for tremor and gait and speech? If you would do that.
That's a challenging question. So I'll try to go step by step. So first, you mentioned a patient has concomitant severe tremor and severe dyskinesia, right? So again, this is I think both targets can be useful here, right? I think the GPI can have a good effect on tremor. It can have, right? GPI alone. In control dyskinesias, right? The other option would be to use, as you mentioned, the dorsal contact in the STN. So we need to have a dorsal contact in the posterior subthalamic area or the zona incerta, right? So especially if it is in the posterior subthalamic area, you can have a good control of both tremor and dyskinesia, right? Obviously, the effect on dyskinesia is not the same compared to GPI, but still you can have a good effect. The advantage of doing that is that if you stimulate the posterior subthalamic area, you can have a very good effect on tremor, and that may allow you to reduce the amount of levodopa, which can target the dyskinesia, right? So that's one option. Now, the other scenario you draw was the patient with speech problems and what was it? Dyskinesia or tremor? I don't remember.
Gait disturbance, speech problem, and tremor. If you would do like low frequency in STM and high frequency in VIM, for example.
Well, you need then two electrodes, right? Two electrodes to do that. With one electrode, you can do what the French group did, and they published a paper early this year. So what they did is that they used the Boston device, and they implanted an electrode in the STN, And they did high frequency, 130 hertz, in the dorsal STN. And they did ventral stimulation with low frequency, 64 hertz, I think, 65 hertz. So they did 65 hertz in the ventral STN, which activates part of the substantia nigra, right? And they did dorsal stimulation with high frequency. That's, I think it's the Montpellier group that did this study, I don't remember. And it's, they had good results, right? This would be one option. Otherwise, I would still do if it's not a Boston device, I would still do dorsal and ventral stimulation using low frequency, as you said, low frequency on both targets, right? If you think about it, even for tremor, if you use not too low frequency, for instance, 90, 80 hertz, and you stimulate strong enough the dorsal STN, you still can control tremor. Okay.
Nice, thank you.
Great, great. Now we have a special participation of Professor Alexandre Novick and Professor Osvaldo Vilela Filho. And Professor Munhoz, Professor Francisco, in live.
Hi, Renato. Good to see you again. I have some questions, and they are kind of provocative. And probably I'll be faced like the devil's advocate, because in the last few years we've been shifting to doing a little bit more GPI than we used to. We still do much more STN for sure, but we're doing more GPI. So I have two questions concerning GPI. So first, obviously we have those patients that when we see them in the postoperative period, they are so good that they seem that they don't have disease anymore. But my question is, don't you think there's a natural bias to see more patients with STN DBS? Because usually we save GPI DBS for patients that are usually they have cognitive impairment, they are older, and they are not as fit as young patients. We tend to do STN DBS for younger patients, so this might be a natural bias selection. And the second question, and this kind of related, when we look at the early STEAM study, if we check the requirements, they were highly selected patients. I mean, they were very, if I can say that, very good patients. And it strikes me that the only quality of life measure that didn't improve in these patients was communication. And don't you think that communication did not improve? Maybe because all of the patients had STN DBS, and there was some impairment at verbal fluency. And if we consider that these patients are highly selected, they are young, they are, for example, they don't have long diseases, that this is another case so we can think a little bit more about GPI DBS?
That's, thank you, Alexandre, for the question. So your observation about the bias is a brilliant observation. So most people miss that, and I missed it initially. So yeah, this is a very good observation. So it may be that those patients are better fit patients, right? So they are the ones we select to go through a more, let's say, risky surgery. And that's true. That's a very important bias to consider, right? Regarding the early STEAM trial, it's another interesting observation. So the effect that reflects basically the impact of STN DBS on verbal fluency in articulation of words, basically, right? Dysarthria, in hypophonia, or dysarthrophonia, right? That's called. So that reflects that, right? In terms of verbal fluency, you know, at least the neuropsychologists here in my unit, they say that verbal fluency, if you have good cognition, verbal fluency is not important. It's something that patients can manage. And I think you can manage if you're not a rapper, right? Or something like that. But still, you need, it's something you need in daily life, definitely. right? So there is an impact on verbal fluency. You need to consider that. So patients with PD, they have problems with verbal fluency naturally, right? But after surgery, there's a stepwise worsening from my point of view. That's true. Yeah. That is, I think that's part. Those results of that trial show this problem also well.
Great. Professor Villela, I would like to invite Professor Villela to, your microphone is closed. Professor Villela, the microphone. Good.
Thank you, Renato. I have 3 points for discussion, actually. First one, what's your real insight regarding the patients with postural disturbance, like the 2 ones that you have showed? What's your insight regarding the patients that may improve with the usual targets? That's the first question.
So I'll answer one at a time then. So the way I'd say explain that from my point of view is that these patients were affected by their postural and axial symptoms deficits were driven by low dopamine, where nigrostriatal deficit effect, not something else, right? We sometimes think of axial symptoms and postural problems as non-dopaminergic problems, right? Related to dysfunction in other areas, not the nigrostriatal tract dysfunction. There are patients whose motor walking and in postural instability problems are related to rigidity, for instance, are related to bradykinesia, right? Or even dyskinesia sometimes. So these patients are more likely to improve. So in other words, if we see a patient who's one thing that when one of my fellows come and tell me about the result of a levodopa challenge, one of the questions I always ask is, how was the pull test in the gait of the patient in the off condition compared to the on condition? If it was bad in the off condition, but it improved in the on condition, these patients may still be good candidates for surgery. And there is a good chance that that problem may improve as well. So that's how I see it.
Right. Well, that's what I say to my patients, actually. Yeah. Well, if the postural disturbance is related to rigidity and or bradykinesia, there is a small chance of improvement after surgery. But if it's not, if it's a true postural disturbance, as one of the cardinal symptoms of PD, it will not improve the usual targets. The other question is, I know that when people say that tremor may get better with GPI, DBS, or lesioning. But in my hands, that does not happen. That's why Romulo asked this question to you regarding the patient who had huge dyskinesia and tremor. Because in my view, at least, these patients will not get better from tremor with the GPI target. And what we have seen actually in a small series of patients is that when you use the posterior subthalamic area, and you know the polythalamic fibers cross that region as well, and also the dendrothalamic fibers, so you can improve both tremor and dyskinesia simultaneously. And you know we have had good results with the posterior subthalamic area for this kind of patients so far, both with lesioning and DBS. So here we in our university, we don't have a large amount of DBS for the patients. So we have to usually perform lesioning in one side, the best side of the patient, and we perform DBS for the worst side of the patient. Mm. So we usually do both. And you know, the results are pretty equivalent doesn't matter if you're using GPI or STN or the posterior subthalamic area. And that's why he talked about this target specifically.
Yeah, I agree. I think the posterior subthalamic area is a very powerful target. It can be very effective in many ways. It's something that needs to be explored. I think in terms of the trajectory of the electrode, the surgeons should all, and this would be something that the clinician should keep in mind as well, that that part of the brain should be, the trajectory should include the posterior subthalamic area. Regarding the GPI per se, I would say, you know, there are studies that show the more dorsal GPI, close to the GPE actually, may have a good effect on tremor. It has a better effect on tremor than the ventral, in the middle of the, middle part of the GPI.
Right. And then I come to my next comment. Paulo, do I still have time for one other point? May I? Paulo.
Yes, I am. I'm here.
Okay.
Yes, we have time. Yes, Osvaldo. For you, we always have time.
Thank you. So just one last point, Renato. There are some papers now on monkeys and also in rodents regarding the role of SNR in levodopa-induced dyskinesia as well. So we're just now starting a new project by using a single electrode with the ventral contact really in SNR to try low frequency stimulation in SNR and high frequency stimulation in STN with the same electrode to treat levodopa-induced dyskinesia with the SNR target, and for the rest using the STN DBS. Would you like to comment on that?
Well, that's a very interesting topic to discuss, and that's something promising as well. This is the SNR is a target that we don't know much about, and I'm pretty sure that we need to find the right patients to indicate that target. The issue is that in the patients that I personally try to stimulate the SNR, those are patients that were standard PD patients with standard symptoms, standard problems to improve, and maybe if you select the right patients with, the ones that as you mentioned, the brittle dyskinetic patients or patients with gait disturbances more severe, you can have a good effect. That's an interesting topic, and I'll be interested in seeing your results in the future.
Thank you.
Thank you, everyone. We have some questions from the audience for Professor Munhoz, and I would like to extend to all panelists. Okay, the first questions. If you use or intend to use the genetic panel to exclude PD patients for DBS surgery.
Yeah, so currently we are analyzing the data we collected over the past few years on the genetic variants that may influence STN DBS outcome. We are currently analyzing that data. It will be published real soon. It was a Michael J. Fox sponsored study that we did here, and we will see the results. Basically, what we used were markers for markers that would indicate a more pure neurostriatal dysfunction, right? But you'll see the results in the next few months, right? But definitely, this is something for the future. This is something that we called here. We baptized this technique as surgical genomics. So surgical genomics for STN DBS, right? That's something promising for the future, definitely.
Thank you. Any panelists would like to make a comment about this?
Paulo, I'd like to add just one comment about this that Renato has recently commented, that for the genes that that are already known for Parkinsonism, those with autosomal dominant or recessive kind of inheritance, there are certain genes that may show bad outcome. For example, GBA patients with glucocerebrosidase mutations, these patients may have bad outcomes after DBS. There are some data about this, and maybe, as Renato has commented, maybe connectomes, surgical, genomics, something that will help us to better select our patients with Parkinson's disease.
On the other hand, you have PARK2 patients, PARK2, who have better outcomes after SCN. Dr. Alexandre Francisco has a patient that I followed when I was living in Brazil with a pallidotomy, unilateral pallidotomy after, and the patient had a PARK2 mutation. That we published that patient, remember Alexandre? We published that paper in Movement Disorders Journal, like 15 years ago or something like that.
Okay.
Patient with that, yeah.
Great, great. Another question is very similar, but if you use in the routine or believe that some biomarker, fluid or image will soon be useful to collaborate in the inclusion or exclusion patient of candidate for DBS, biomarker.
Yeah, as Dr. Godeiro mentioned, I think that in the future, once we are able to map the connectomes very well, I think the connectomes is a revolution in brain physiology, I think, and anatomy. It is something that will change things, definitely. And will, you know, in the future. Not something we do. Yeah. Not now. Yeah.
Any panelist would like to comment?
I'd like to add another comment about that, Paulo. Renato and the other panelists, what do you think about the non-invasive neuromodulation methods for selecting patients? For example, TMS, DCS before surgery. For example, there are some patients for spinal cord stimulation that when they have transspinal cord stimulation, TMS in spinal cords, and they present response, maybe it's a clue for a better response after the surgery. What do you think about that? That the neuromodulation, the non-invasive neuromodulation methods, they can help us or not? What do you think? It's still a clinical decision.
From my point of view, the way I see non-invasive neuromodulation is as a proof of principle, experimental procedure, right? Is a way you try to prove a principle. For instance, if you're doing, we are actually trying to start now a trial of dentate stimulation for ataxia, and we used results from TMS studies to use as a base, as a background for knowledge for this idea. And I see mostly as a proof of principle. I don't know if anyone else has any additional comments. Maybe someone who does spinal cord stimulation frequently, like Alexandre, can comment. I don't know.
Great. Professor Antonio Almeida would like to do a question. Professor Almeida.
Okay. It's just a simple question. People, well, we have heard a lot about directional electrodes. Do you think there's a patient with some special feature that may benefit from directional electrodes as the first choice? Or do you think it's just another option when there's a failure to the regular one?
Yeah, at this moment, again, I mentioned about studies that we're analyzing data. This is another one. We're analyzing the data from, we're not analyzing yet. We're still finishing to collect our last patients to our trial of comparing directional versus non-directional stimulation. And currently, based on our limited experience so far, the patients we select we give preference to patients with speech problems, right? Because speech, despite the fact that the surgeons here are, like most of you guys, are obsessive with placing the electrodes in the right spot. Sometimes even with the well-placed electrode, you can have speech problems, right? And for patients who have speech as a feature, and they don't want to, you know, risk any worsening, the patient is undergoing STN DBS. We try to move to the brand that markets the directional lead. This seems to be an option. Today in my clinic, I saw a patient that we need to steer the current to improve speech. And I think that's the main indication, right? We need to keep in mind that the electrode that is the directional lead, it's a smaller electrode, right? It's not like the 2387 from Medtronic, which spans from you can span, for instance, in the STN from the SNR to the zona incerta with the 2387, right? But still, it's not, there are advantages and disadvantages. I think one of them is to have another choice for speech problems.
Okay.
Great. I would like to extend the Professor Almeida question for all panelists. If any panelist would like to answer Professor Almeida's question about directional lead.
I just have a complementary question to Antonio's. And Renato, if you have a patient that preoperatively, he has some speech disturbances, in order to avoid, of course, directional lead is a good option, is a very good strategy for these patients. But do you consider, for example, sacrificing some of the motor benefits you may have from the sweet spot of the SDN and putting your electrode like 2 millimeters posterior so you can avoid speech problem, and then trying to program that with the directional lead? Do you think that's a good strategy?
That is a very good strategy. Actually, we know that from a couple of studies that most of the speech problems are related to interference with the cerebellothalamic fibers that are ventromedial to the STN, right? So if you move more dorsal and a little more lateral, you may not interfere with those fibers, or just to avoid those fibers. But anyway, if you can avoid the lesioning effect in those fibers, which are ventromedial, that would be that's a good strategy, definitely.
Great. The next question from audience is very important. If you have any precaution in the surgical indication of patient with dysautonomies, PD dysautonomies.
So yeah, dysautonomia in PD. Let me think. So if a patient has severe dysautonomia, it is disabled by dysautonomia prior to surgery, that may be a contraindication for surgery to begin with, right? On the other hand, if you have a dysautonomia that is clearly linked to medication, right? It may be advantageous to try STN stimulation to get rid of or reduce the amount of medication in a way. Yeah, I don't know. That's a good question.
I think it's a red flag for atypical,
yeah.
isn't it?
Yeah, if it is severe enough, it's a red flag for MSA, right? But anyway, or even the Lewy body dementia or MSA, right? So you need to be, but then there are other features, but definitely that's true, Gabriela.
Any panelist would like to comment this question about dysautonomy in PD patients?
There was a recent publication in Movement Disorders Clinical Practice about that, discussing the effects of deep brain stimulation in patients with dysautonomia. And the link was exactly what Renato said. Maybe we could improve some side effects of drugs, reducing them. Yeah, that's a very interesting publication if the person is interested in reading.
Great. You comment about DBS and PD patient with previous unilateral pallidotomy or thalamotomy. Some comments about this. Patient with previous unilateral pallidotomy or thalamotomy. If you have any precautions about DBS, indication or no indications.
Yeah, so this is a dilemma that we often see, and I remember that Dr. Lozano commented on a few times about his cases. We don't see too many of those cases anymore because we don't do. For a long time, we've been not considering lesional surgery here, but we often see those cases. So we shouldn't expect to have the same improvement that you see in a patient who has never had any lesional surgery, of course. But you can, if the problem is severe enough to still warrant surgery, I would still consider. Yeah, you can have good effects. I know that Alexandre, that I follow, I know more closely, he may have patients who have had double hit.
Any panelist would like to?
Yeah.
Any panelist has opinion about?
I just think that you have to be very careful. For example, I never had patients with, or at least I don't see them anymore, patients with subthalamic lesioning. Osvaldo has a big experience, he has published about it, but most of my patients that were submitted to radiofrequency lesioning were pallidotomy patients. So every once in a while, some of these patients would come back and they would require surgery for the other side. And it's one thing that we have to keep in mind for these patients is that you cannot put an STN DBS. It doesn't matter if you analyze the patient and you think that this patient is suitable for STN DBS from a clinical perspective. If you have a pallidotomy lesion on one side and an STN DBS on the other side, you may have really big problems, especially for the neurologist to adjust the levodopa regimen. So this is only one of my remarks. So never do that because it's almost impossible to cope with the patient.
Yeah, one of my.
I agree.
Yeah. So yeah, one of the issues I think that I always mention, in general, unilateral STN DBS means trouble, right? Because you'll be dealing with a patient, with two different patients in one patient, right? You'll be dealing with a patient who needs levodopa to treat one side and it needs to stay away from levodopa on the other side.
Yeah, and they want you to improve the DBS side, but you can't because you would worsen the other side.
That's the same issue with the pallidotomy and STN, contralateral STN DBS. It's impossible. It's a mess.
Yeah.
Right. Great. Okay. The last question, I believe, because our time is finishing, is very interesting question about interleaving. Interleaving can improve instability or the interleaving programmation could improve instability or the axial signs. Renato?
So yeah, so interleaving, some people have the wrong impression about this technique. So this technique basically allows you to remodulate your electric field, right? That's what it does. So with interleaving, you can activate two contacts alternatively, right? They alternate, and with half the frequency, right? With lower frequency usually than if you activate only one contact. So they alternate. And in the effect on any symptom, any motor symptom that you see, it relies on the target, right? So you can improve axial symptoms, for instance, if you do interleaving of one target that may improve axial symptoms. So if you do SNR, for instance, with one target, alternating with a more dorsal contact in the proper STN, you can do that, yeah. But it's not an indication or something that you consistently can address with interleaving. Interleaving is a limited option in many ways, but it can be helpful in some patients.
Yeah, I would like to extend the question for panelists. Any panelist has experience with this?
Yeah, interleaving we use more for example, dyskinesia, when you can add the dorsal contact, or maybe some tremor that's residual. I think it's good. And in the more modern devices, when you can use the ventral one for low frequency and try to treat axial symptoms.
Yeah, that's one of the main uses, doing as you said, so activating the zona incerta in the ventral contact. Yeah.
Okay.
Yeah.
I would like to say thank you for all. It was very important webinar because was the many 1, 2, 3, 4, 5, 6 panelists. Thank you very much for all. I would like to invite our president, Professor Antonio Almeida, to closing remarks.
Okay, it was an amazing presentation. I would like to thank you for your very elegant lecture. And I would like to thank all the panelists. I think it was a great moment to put together neurologists and neurosurgeons. I think this kind of mix of different experience is fundamental for a good results in the patients with disease like Parkinson's disease or epilepsy. I think this kind of interaction is really necessary. It's the reason why we called some neurologists here, despite it's a functional neurosurgery society. I think you are a very important part of our society. So I would like to thank you all and the attendees, the panelists, everybody. And I hope to see you soon. Bye.
See you.
Thank you.
Best
Thank you.
wishes. And Professor Clécio, Elena once told me that you were one of the best fellow in Grenoble that came from Brazil. Congratulations. And for all, thank you very much. Best wish and take care. Bye-bye.
Bye-bye.
Renato, great lecture.
Thank you. Thank you all.
Bye-bye.
Gabi,
See you.
bye-bye.
Ciao.